Good afternoon, everyone, and you're very welcome. We'll just wait a few moments while you enter the room. Okay, good afternoon, everyone, and you're very welcome to this Endo-ERN webinar. I'm Amy Casey, and I'm the Communication Manager for Endo-ERN. It's my pleasure to welcome you and to welcome our speakers who have given up their time to put this presentation together. We're very grateful, and the webinars from Endo-ERN are always well received and very informative. Before we get started, I just want to bring to your attention some housekeeping. The panel will have a discussion after the presentation, and they welcome your questions. If you can use the chat box and enter your questions there, or you're very welcome to enter the, to raise your hand, and I will unmute you, and then you can ask your question directly to the panel. We're delighted to have chairs from MTG 7 today, Professor Olaf Hiort and Professor Luca Persani. And Professor Hiort is going to introduce our speaker for this afternoon. So with that, I will hand it over to you. Thank you.
Yeah, thank you very much, Amy, and thank you very much for organizing this webinar, and welcome, of course, to all listeners, because I think we have a very well and good topic for this upcoming webinar on pregnancy in congenital adrenal hyperplasia. Of course, Luca Persani is more into the topic in a way that he's an adult endocrinologist, but the outcome of a pregnancy is, of course, something for pediatrics. So I think it's a well-received transitional topic. And with this, I'm glad to introduce Nicole Reisch, who is an adult endocrinologist. She's a professor at the Institute of Medizinische Klinik in Munich with Martin Reinke. And she has an outstanding record, I would say, because she has received one of the highest awards for professorship, being a Heisenberg professor by the German Research Foundation. But of course, she's well known in our vicinity for her work in Endo-ERN, but she's also very much engaged in ESE, and she's also a member of ESPI. And currently, she's also vice president of the German Society of Endocrinology. So you're not only an outstanding researcher, but also very much involved into administrative and our bureaucratic work. And I think you have engaged enormously in Endo-ERN, and we are very grateful for that. So today, the floor is yours to give this webinar on behalf of adrenal and also sex development and maturation. It's a very good and overarching topic. Thank you, Nicole, for giving this lecture.
Yeah, thank you, Olaf, very much for this very nice and kind introduction. And yes, I'm happy to talk about pregnancy in CAH. That's indeed one of my favorite topics, I have to say. And I'm happy to show you some data and also some very positive data, I think, and positive developments in the last few years. This, I have to show this first as my disclosure. And I would like to start just very briefly with some background. You're all well aware that congenital adrenal hyperplasia is an inborn error of cortisol biosynthesis. It follows an autosomal recessive trait, and mostly it's due to 21 hydroxylase deficiency. And we distinguish a classic and a non-classic phenotype. And what you see here is that you all know that CAH triggers the release of ACTH, and that is responsible for cortisol release. And in these patients, we have a defect in cortisol biosynthesis, and therefore an excess of adrenal androgens. If you have a closer look at the steroid biosynthesis of the adrenal here, on this level, you see that the adrenal synthesizes mineralocorticoids, glucocorticoids, and androgens. And here now is the block of CYP21, and that means that we have a lack of cortisol, which can be variable, and in the severe form also of aldosterone. And before the block, we have an accumulation of these steroid precursors, in particular 17-OHP, 17-hydroxy progesterone and progesterone, and they then can be synthesized to androstenedione and testosterone, so to androgens released from the adrenal, and this leads to a disturbance of the hormonal balance in affected patients. So what we do, what you all know, is that we treat the patients. Here you see the leg, and this we have to replace by our treatment right from the beginning. So in the severe form, all newborns in the Western countries now are screened by newborn screening. So from the very first day, they receive glucocorticoids and mineralocorticoids, and if it's detected later or in the non-classic forms, then as soon as we detected it, has to be treated if there's a cortisol deficiency, because cortisol, as you all know, is an essential hormone, essential for life. Now we come to the main, just as for an introduction to fertility in the general population and in CAH. This is quite old data from 2009, but it still holds true that fertility is substantially reduced in patients with CAH. So this is the female population here in the UK with 1.8 live birth, and this is also in other European countries about the same. And in females with the classic form of CAH, we only have a fertility rate of 0.25 live birth per woman. And what we also need to know as a background is the autosomal recessive trait, inheritance trait. And here you can see this pedigree and see that the affected female, that would be now the affected female with like 2 classic mutations, and mostly it's 2 different mutations. So patients are compound heterozygous for 2 classic mutations. It can of course also be homozygous, but mostly the patients are compound heterozygous, and then the father cannot be affected. And if this is the case, then all children will be carriers but will not be affected by the disease. And if we have this constellation, so an affected mom and a carrier as the father, then you can see that we have oh no, this is now, sorry, I have to be sorry because this is a non-classic constellation here, but this shows that even if you are a non-classic female, children can be affected by the classic form in 25%. So if the father is also a carrier of the classic form, and this might be important for the genetic counseling. And in most of the cases, of course, we have this constellation where parents are heterozygous, so they're only carriers, they're healthy themselves, but 50% then of the offspring can be carriers of the classic mutation, and 25% again will be affected. And in this constellation with children that can be affected, we have the possibility of the experimental treatment already prenatally, but this is a different subject, so I will only mention it here, but I will now refer to pregnancy and pregnancy outcome if a mother is affected by the disease. And we all have now seen that fertility rate is low, and this has many reasons, psychological reasons in this patient cohort, because of different gender behavior, low maternal interests also in motherhood, but also post-surgical difficulties, for example. So that's very a very difficult topic, and has many reasons. But this study here has looked deeper, and they have shown already a while ago that the most reason is that most women never tried to conceive because of psychological reasons, or because they were just convinced or told that they are not fertile. But if they try to conceive, then they can really achieve pregnancy, and the pregnancy rate in the end is the same as in the normal population. And this holds true both for the very severe salt wasting phenotype as well as for the simple virilizing phenotype. So statistically, there is no difference, and that's very important to communicate to our patients that if they want to conceive, they can conceive. And we have then looked in our cohort just recently and presented this data last year on the European Congress at 133 pregnancies in 72 adult women with CAH. And we included the non-classic form, the simple virilizing, and the salt wasting form from 7 centers in several countries. And we found that the mean birth weight was normal. It was lower than in the general population, but it was normal birth weight, the birth length as well, and the median APGAR score was also normal. And if you have a look here at this cohort, what we found is that many of these patients, so irrespective of what phenotype, half of the patients have irregular menstrual cycles. Only half have regular cycles, and that makes clear that this hormonal imbalance makes it difficult to achieve pregnancy, but it's possible. And what we see here is that the time to conceive is really longer. So it's between 12 and 24 months. In medium, so it takes 1 to 2 years until they can conceive, and that's of course significantly and substantially longer than in the general population. And that's the main problem. It's not that they cannot conceive, but it's difficult to achieve this optimal hormonal balance that they finally conceive, but we can do so. And another important message or finding is that we know that the rate of cesarean section in this cohort is really very high, and it's a lot higher. And of course, in the classic patients, this has to do with post-surgical changes, genital changes, but also in the non-classic population, it's really high. And the question is if it needs to be that high. In the non-classic population, we know that also here there is a very high spontaneous rate of pregnancies with low-dose glucocorticoid therapy, but we have to be aware, what I just showed initially, that half of the patients are compound heterozygous also in this population, so a mild phenotype might be carrier of a severe phenotype on the other allele. So also these couples have an increased risk for a child with a classic form of CAH. That's important in our genetic counseling. So it's important to screen the partner for a carrier status for the counseling, for the genetic counseling. And there is a subfertility rate in the non-classic females with CAH. Also 25% have a polycystic ovary morphology. That is important to distinguish this from PCOS as a syndrome, just a morphology, but PCOS is a diagnosis of exclusion, so we only call it morphology. But also here we can achieve a normal pregnancy rate with low-dose glucocorticoid therapy, and the time to pregnancy is shorter if we treat these patients with a low-dose glucocorticoid therapy 1 year versus below 6 months. So it makes a difference if we treat these patients, and it also makes a difference for the miscarriage rate. There's 2 publications nicely showing this independently from each other, where in this cohort there were 107 total spontaneous pregnancy, and there was 26% of miscarriage without glucocorticoid treatment, and this could be reduced to 6% with glucocorticoid treatment. And very similar numbers also are shown in this publication. They show exactly the same numbers in another cohort. And now the question is, how can you achieve this hormonal balance, and what is really the reason? We know, I told you the psychological factors, post-surgical difference, but the precise mechanisms why these patients have such a high number of menstrual irregularities is not really well known and understood. We know that there's a hormonal imbalance, but what exactly causes this and how can we reach this goal to achieve pregnancy? This is difficult. And I would highlight this publication that has investigated LH pulse patterns in a cohort of CAH patients, 16 patients, compared to 16 female controls. These 16 female controls all had regular cycles, ovulatory regular cycles, whereas in the patient cohort, just as we know it, there were 6 with regular cycles and then 6 with amenorrhea and 4 with oligomenorrhea. So the majority had indeed irregular or no cycles in this cohort. Otherwise, they were the same with regard to age, BMI, and also here there was a higher number of hirsutism due to elevated androgens. So what they investigated now is the LH pulse pattern over 6 hours. They took blood every 10 minutes over 6 hours in the morning from 8 a.m. to 2 p.m. and wanted to see if this might be the reason, as we know, that this affects ovulation. And what they found, they didn't find a difference in mean LH levels, pulse amplitude or frequency, but they saw a very heterogeneous pattern in the patient cohort. So they were all over the place, the LH pulse patterns. And when they did a cluster analysis, they found that these can be separated in 2 clusters of LH pulse frequency and amplitude. And cluster 1, this cluster here, had very similar pulse amplitude and frequency patterns to the control group, whereas this cluster here had a lower pulse amplitude and frequency. And that's why they, in the second step, then looked at these patients from cluster 1 and cluster 2 to see how these patients differed clinically and hormonally. So in the cluster 2, 7 patients had, and of these 7 patients, 5 had regular cycles, so very similar to the control group. This obviously makes the difference. And in cluster 2, only 1 had a regular cycle. Otherwise, there was no difference. And when they had a look at the hormone profile, they found a significant difference between cluster 1 and 2. In particular, 17-OHP and progesterone differed. So this was the biggest difference between these 2 groups, but they also differed in testosterone and androstenedione, and and also LH-FSL. So we know beforehand from other data already that progesterone affects LH pulse frequency and decreases it, and this obviously is the case. And so they concluded here that progesterone has the highest effect, and also 17-OHP, on this LH pulsatility, and this affects ovulation and endometrium receptivity. So the conclusion here was that if no spontaneous conception with regular or so prednisolone or hydrocortisone replacement within 6 months, you should achieve a low progesterone, because this can normalize LH pulsatility. And this was also already found in the publication by Casteras et al. That I showed initially, where they showed that you can achieve pregnancy if you have an ideal hormonal profile. And they also found that progesterone obviously makes a difference without having looked at LH pulsatility. And they then concluded that a cutoff from their experience only is that progesterone should be below 2 nanomole per liter, which equals 2.63 nanogram per milliliter. And I highlighted this. So just keep this number in mind, because I would like to present a case later on. And there it's important that we have these numbers in mind. So the goal is to normalize progesterone to achieve numbers below 2 nanomole per liter and below 0.6 nanogram per milliliter. So if we then achieve pregnancy, because we reach this goal by treatment, then what do we do during pregnancy? During pregnancy, monitoring is of course important, and there we have to know that actually all parameters of our disease control change during pregnancy. All markers change. 17-OHP increases throughout pregnancy. Androstenedione increases by 80% by gestation week 12 roughly, and then remains more or less constant. DHEAS also increases, and we also know that of course renin increases progesterone, so we have to know the concentrations per trimester for pregnancy to be able to interpret the hormone values and disease control during pregnancy. That's important. And so we do clinical monitoring in these patients, and from experience we know that cortisol increases in the third trimester, and there's a higher need. So we roughly increase the glucocorticoid dose by 20 to 40% in the third trimester. And of course, clinically, we monitor blood pressure, electrolytes, edema, weight gain. And during delivery, patients, of course, need stress dosing. So we have to adapt the dose. And usually we give the patients a written stress dosing for their obstetric department, how they should increase the dose. And it's also important for the patients then to know that breastfeeding is recommended. There's only very negligible amounts of glucocorticoids going into breast milk. So this is possible. What else is important to know, in particular here with the dose increase, because there's a tendency to increase the dose. We think, well, if there's no other problems, there's no gestational diabetes, blood pressure is fine, what is the harm in increasing the dose? Rather give a bit more instead of less. But also here it's tricky, and you have to find the right balance, because if the dose is too high, this also has detrimental effects. And what is important to know is that glucocorticoids stimulate the expression of CRH in the placenta. We know that already quite a while. This study has done experimental data where they examined the expression of CRH gene in placenta by synthesis and secretion in primary cultures of mRNA and peptide levels. And with an increase, here they gave dexamethasone as glucocorticoid, a strong glucocorticoid. There's a clear increase in both mRNA and peptide levels of CRH in placenta with glucocorticoids versus without. And why is that important? Because CRH, on the other hand, correlates with gestational age and fetal growth. So if we give a too high dose of glucocorticoids, this triggers more CRH, and we know that there's a clear correlation of CRH concentration at the end of pregnancy with preterm delivery and fetal growth, small for gestational age. So we also know that there's a higher percentage of preterm and small for gestational age in this patient population, and that might be also then correlated to the dose of glucocorticoids. So it's important also here to find this delicate balance, not to overdose on the one side and also not to underdose. So that's how we should treat during pregnancy. And now I would like to share a case report with you, presenting you a female patient, 30 years old, with a simple virilizing form of CAH. and she was diagnosed at the age of 2 years, so that was before newborn screening, and she was then treated with hydrocortisone during childhood. She had normal pubertal development, genital surgery at the age of 16 years. She had actually irregular cycles, but she had cycles, and she was treated with hydrocortisone, 15, 10, and 5 milligrams, so 30 milligrams altogether. Not so it's a reasonable dose, but it's not a low dose, it's rather on the high side. And besides, she had L-thyroxine, no hirsutism, no aqua, otherwise she was healthy. So she came and presented that initially with this lab results, and what you can see is that 17-OHP is clearly elevated. Also, testosterone is elevated, the free testosterone index, and androstenedione. So it was okay, but she was, of course, not perfectly controlled here, as you see with hydrocortisone with this regimen. Even she had quite a high dose, and now she wanted to conceive. And just to give you here a background again, cortisol profile. So that's our physiological curve that you all know with the circadian rhythm of cortisol. And in this patient, we gave 5 milligram in the evening, 15 in the morning, and 10 here. So that's about the curve that resulted in this patient. And you can see that there is a lack of cortisol during the night, and that's exactly where the androgens are produced, where no cortisol counteracts the building of androgens. So there's no cortisol feedback, and then androgen and precursors are increased. And as you've seen, these parameters were increased in this patient, and now she wanted to conceive. She wanted to become pregnant. So what do we do next? So we decided to change her to prednisolone as a longer acting synthetic glucocorticoid, where we can extend a bit glucocorticoids into the night. And we know from experience that often this results in more regular cycles and ovulation. So we changed her to 1 milligram in the evening at night and 4 in the morning. And indeed, her profile here improved. The cycles were still irregular, but her 17-OHP went down from 60 to 5.5, so it's still elevated. Also, progesterone is elevated. I told you before, we aim at below 2 nanomole per liter or below 0.6 nanogram per milliliter, so below 1 at least nanogram per milliliter at progesterone. And so we are far from this. And in the morning before the intake, we see it's still hugely elevated because this is always before the intake of the medication. The patients do it at home. This is after the intake, so after the intake it's quite okay, but before we see that overnight she's not perfectly controlled. So what did we do? We increased the dose to 5 and 2.5 in the evening, and she got better. It went down here after the intake in the morning, but overnight it was still not ideal. Progesterone got better, but it's still elevated. So then we added fludrocortisone, and we switched to a 3 times daily regimen of prednisolone to have it more equally distributed instead of twice. But we see that overnight it was better. Now in the morning she went down here, but progesterone didn't go down in this patient. And then after a while, so we lost, this was quite a few months, I think it was already a year into that. In January 2021, we sent her to fertility clinic, and she had her first IVF cycle because we said we cannot do any more for that. But this was not successful, unfortunately. And then we discussed with the fertility clinic that we may put her on dexamethasone at bedtime, even so usually we don't like to give dexamethasone because it also passes the placenta barrier and has an effect on the fetus. But with that, we hoped that we can bring progesterone and 17-HCP further down to allow a better endometrium receptivity and to allow conception. And we could bring 17-OHP down, but progesterone also went down, but it's still above 1. Morning 17-OHP was now nicely suppressed, but the patient had substantial side effects. So with this regimen of dexamethasone, she gained weight, and so we reduced it to 0.5 dex at bedtime, but this didn't help, so she didn't conceive. They did more cycles and more treatment, but this was all not successful, and progesterone went up again. It was even higher than ever before. Maybe she was not that compliant anymore at the time. We were not quite sure, because it was very frustrating for her, of course. It was now 2 years from start, and we didn't have any success. So we talked again to the fertility colleagues, and they told us, well, they did everything, they froze everything, did cryoconservations of all pronuclear stages, and she had 2 unsuccessful egg transfer and still had elevated progesterone, so that they said, well, they cannot do any more for her. It doesn't make any sense with this elevated progesterone, and we cannot bring it further down, even with dexamethasone, to continue fertility treatment here. So the patient was fine with this. She said then she has to accept it. And in the meanwhile, the study on modified release hydrocortisone, phase 3 study, was running. And in this study, we have seen that with the modified release preparation, indeed, several patients have experienced improvement on menstrual cycles. And also in the prolongation study, we have seen that. And there were partner pregnancies documented and persistent pregnancy in the extension study on modified release. But of course, in the study, the intention was not to get pregnant, so this was not a primary outcome marker. But we thought maybe this is a possibility, and in the meanwhile, it was on the market. It was just launched in Germany in September 21. And so we switched the patient to modified release hydrocortisone 10-25 in the evening, so 35 milligram altogether, because we thought we will start rather higher. We knew she was on 30 milligram before hydrocortisone, and she had really high elevated 17-OHP and progesterone. So let's start with this dose, and it's just the last try. She had excellent hormonal control. No subject, she didn't feel any difference personally, and she said, she called us, she said yes, her cycle is regular again with 5 weeks, and she was supposed to come back to our outpatient clinic 3 months later. And then in April, she was supposed to come, and she came to our outpatient clinic, and she reported on a spontaneous twin pregnancy. And at the time, she was already 8-week pregnant. And it was, for all of us, it was really a big surprise, and we couldn't believe it, and the patient couldn't believe it either. She really sat there crying in our outpatient clinic because she couldn't believe that after all these years, she now got spontaneously pregnant. She had a completely uncomplicated pregnancy. We didn't change the medications throughout pregnancy, and in the end, in October 2022, she delivered healthy twin girls. And unfortunately, we didn't have a chance because she came back and she was already 8-week pregnant, so she must have been pregnant after the first month of modified release treatment. We didn't have any lab values before under modified release where she hasn't been pregnant. But afterwards, we then, after delivery, we took her blood samples on FMODI and checked her lab values. And what you can see is that with this treatment here, 17-OHP was completely suppressed, and as well progesterone, androstenedione, and morning saliva. So here we managed with a lower medication than before, with dexamethasone in combination with prednisolone, to really suppress these values. And meanwhile, we have reduced her dose to 10 and 20, and even now, just recently, we went further down, and she is still on a stable, not as low anymore, but she doesn't wish to conceive anymore. So there's no need to suppress her that much anymore. And she keeps good values on a lower dose. She's now on 10 and 15 in the evening. So this was a real big surprise for us, and I just want to show you some data on the cortisol secretion again. So as you all know, this is the physiologic normal release. That's what we have about with the 3 times daily hydrocortisone treatment. This is like the extended dual release, where we have this curve, and with now the modified release hydrocortisone, we can mimic this overnight rise, and this seems to be important in my view, and in particular in fertility. With fertility issues, this seems to make a difference. This was now an illustrative case, and we have since then actually several pregnancies, and are putting these together now, and it's really amazing how the time to pregnancy is shorter, and how the better hormonal control overnight in these patients adds to pregnancy achievement. And just to give you again the data from the study, here we have seen in the standard glucocorticoid treatment arm that the patients before the switch to FMODI had elevated 17-OHP, and this improved in the study. So this was no switch. They just stayed on there because they were improved on their medication. There was a dose adaptation. They still improved, but this is just a study effect, I think. But you can still see that in the morning, 17-OHP remains increased, whereas in the modified release group, this is before they were switched, so they were still on baseline on their standard glucocorticoid treatment. They had even a worse disease control compared to the other arm. And afterwards, where is it? Here, this curve. Afterwards, when they were switched to modified release, you can see a completely flat and a completely normalized curve, what we never achieved before with the conventional hydrocortisone or prednisolone treatment. And this contributes, in my view, a lot to fertility in these patients. So I would like to sum up that pregnancy rate, as we've already known beforehand from data, is comparable, but the patients have a lot longer time to pregnancy, at least under conventional treatment, as we've known it before. Spontaneous pregnancy rate in non-classic patients is high, but it can be increased with low-dose glucocorticoid treatment, and in particular miscarriage rate can be reduced. If you don't achieve pregnancy with conventional glucocorticoid treatment, prednisolone or hydrocortisone, then I think that a switch to modified release is absolutely justified, and this may be the main indication for modified release hydrocortisone in this patient cohort, in my view. And otherwise, the course of pregnancy, no matter under what glucocorticoid, is mostly uneventful. They have more cesarean sections and lower birth weights, but otherwise they're fine. And the lower birth weights may have to do with a too high glucocorticoid dose as well, because we may trigger lower birth weights here. So it's also important not to overdose and not to increase the dose too high in the last trimester of pregnancy. And here I would like to conclude and thank all the people that contributed to the work in my group, and of course to all collaborators, scientific collaborators, and you for your attention. And I'm happy to discuss the findings and the talk with you. Thank you very much.
Thank you, Nicole, for a very nice and interesting presentation. And from the panel of the presenters here, I welcome Giorgio Dal Maso, who joined us now from the patient advocacy. I think a very interesting and good presentation. And before we go into the questions, I don't see the chat if there's anything in there. But
I don't see anything, no.
But I mean, from a pediatric point, you said the outcome of the children is good, but is there long-term outcome? Maybe I didn't get that, because of course you would, well, steroids of course have been involved in cognitive development, so you would see that only at the
Usually, if you don't want to do prenatal treatment, mothers are treated with hydrocortisone or prednisone, also now modified release hydrocortisone, but hydrocortisone that doesn't affect the fetus. That's not passing the placental barrier, so it shouldn't affect the fetus. And that's why we don't expect real differences here, except that of course it triggers, that's the only thing I found, the CAH release from placenta, and that again seems to be responsible and connected for gestational age and preterm. So that's and that's what we see. And of course there is more and better data from non-CAH offsprings in small for gestational and preterm babies, and I think there's no difference. And I'm also not aware of a study comparing them. So I'm not aware of any study examining offsprings of moms beyond the neonatal period. So all data that we have has just examined the children just in the neonatal period, for length, for height, for weight, for APGAR score, these things, but not beyond that. Yeah.
Yeah, thank you. My co-chairs, do you have questions?
Yeah, I wanted to ask about the miscarriage, the mechanism underlying the miscarriage. Is just the progesterone, or there is something else that is contributing?
So androgens will also contribute to the miscarriage, I think. So there is no, we know that from the non-classic patients in these studies, they have compared also the groups with miscarriage and non-miscarriage, and they find higher androgens as well. So that must be somehow linked, but the exact mechanism is unclear in my view.
Is unclear. In animal models, there is no
not that I'm aware of.
to. Okay,
no.
And you know that we have a CAH antagonist that is coming and appears to be quite effective in the treatment of our patients. But how do you envisage the use in pregnancy?
Mm-hmm. I mean,
the CAH antagonist.
This is really
interesting.
Also,
yeah.
I mean, we don't have any data on pregnancy, of course, because it's not given in pregnant women yet, and if that will be done or not. But in theory, this, of course, could also, if it doesn't have an effect on the fetus, it's not transmitted, and so could be ideal, because then you could even lower the glucocorticoid dose on the mother as well, and really try to only give replacement doses. And we know that at the moment replacement in CAH is still higher than what is a pure replacement dose, because we want to suppress, of course, progesterone and androgens. And if it was possible to only give 6 to 10 milligram per square meters, because we can lower the CAH drive or the ACTH drive. That might help a lot, yes, but no one really knows. I mean,
no, but I mean also the passage through the placenta barrier would cause problem. I think yes, no.
Yes, most likely. If there's a, but I don't know if there is it known that this will go via the placenta. I don't know. I think it's not known yet. I mean, if it really does a placenta passage, that's problematic. And the question is if anyone will really try, or if it will be just a contraindication for pregnancy. But in theory, if it's not, this has an effect on the fetus, then it would help for the mother and to reduce glucocorticoids, as we most likely will see in the studies now. Maybe it's also possible to just give it until pregnancy, you know, to achieve pregnancy and then stop it, as we've long done it with metformin and everything, and then stop it. And once you have achieved it, because it's still the highest barrier is still to achieve pregnancy. And once it's achieved, you still have maybe a bit higher miscarriage rate, but the biggest problem is to achieve pregnancy and to get this hormonal balance, to have a spontaneous conception and to have ovulation, because many have just anovulatory cycles. And here it still could help. And then you just have to stop it as soon as you're pregnant. That might be an option, and I think it will be performed and will be practiced.
Yes. I don't know if Giorgio has some questions.
No, sorry, no question. Really interesting the argument, because I'm father of two daughters, 19 and 17. I think that this argument will be very predominant in the next phase of the life of my child. So really interesting, but I'm no doctor. I'm not so expert. So I have a question. Thank you to Nicole for the constantly and unwavering commitment to help us. Thank you.
Nicole, so I saw that during the modified release hydrocortisone, you didn't increase the dose during pregnancy. What is the reason for that? Because you started with high doses, or because something else happened?
Yes, we have seen that the dose was quite high and it was sufficient. So all the lab parameters, so according to pregnancy, were in range. She felt okay. We didn't have the feeling clinically that she has a higher need, and that's why we were hesitant to increase it, because she was doing fine, so there was no clinical need, and also lab parameters. And I was rather afraid in the twin pregnancy to trigger a preterm birth if it's too high. So in the end, I think it was a good decision, but it's always difficult. Yes.
But you excluded that the father was carrier of was heterozygous carrier. Okay, yes. Okay. Because the two girls are heterozygous carriers.
Exactly, they're both carriers. Yeah, they are carriers, but they are not affected both. Yeah. Mm-hmm. But even if he was a carrier, I think we would not have changed anything, because in a twin pregnancy, I would never do any prenatal treatment. You know, even if there was a risk, because then you don't know which twin, and you always treat one maybe in vain, and also it's a risk pregnancy. So even that, we would never do it, and that's why it wouldn't have had a clinical consequence.
They were dizygotic.
Yes, they were.
Okay. And yeah, at the end, you mentioned the polycystic ovary morphology. So for all the audience, you mentioned you have to be efficient in making the differential diagnosis with PCOS. on what basis would you differentiate the non-classic, mainly the non-classic form from PCOS?
Well, yeah, the morphology is the same though, but per definition, as soon as someone has a genetic underlying cause as CAH, even the non-classic form, per definition, it cannot be polycystic ovary syndrome anymore because it's a diagnosis of exclusion. So you have to exclude all other endocrine reasons for menstrual disturbances or hyperandrogenism, and if that's excluded and you still fulfill the Rotterdam criteria, then you can name it polycystic ovary syndrome. But it happens quite often that we get the diagnosis that patients have CAH plus polycystic ovary syndrome, and that's why it's important, I think, to let them know that's a difference and that's two different diagnoses, and these two don't go together.
Yes, yes. Okay. I don't know. Chairs, do you have other
I mean,
comments?
Using with a modified release, do we monitor those data in the ICAH network, or how is it monitored that we get more data in a short time? Because this is very valuable information, and I hope that a lot of people will, of course, download this webinar later, but it will be extremely helpful for all pregnancies. Do you know if it's monitored in ICAH or in what registry?
There is currently ongoing, like investigating the effects of modified release versus not. I'm actually not 100% sure. That's really a good question we have to ask if pregnancy is really in. I don't know. I haven't put it in recently, but that's very important that we monitor it. Yes.
Yeah, it's a good thing for also
and we
for
document it. Yeah, absolutely. I think that's very important, and we should do that. We'll ask Faisal, and because we want to connect our data anyways completely. And but I think for patients, it's a very important message that they know that they can conceive and that it's getting better and better. That in my view, this is a game changer from my observation now with regard to pregnancy. But we still have a lot of patients. We know this also from our study in Germany, from the DST Care project, that the information is still, there's such a lack of information to the patients that they often just don't know or think or are convinced that they cannot conceive. That this is so important to inform patients, to inform also doctors, other disciplines, that they have a normal pregnancy rate. And if they wish to conceive, they can conceive.
yeah, and this has to be
It's a good idea to have a specific module on Eureka, on the core
Eureka.
registry.
Yes.
On the core registry, sorry. Yeah.
Luca, there's one question. Could you comment on prenatal treatment with dexamethasone in high-risk pregnancies? I think
I don't see it.
Yeah.
Answered.
In my experience, all of the prenatal treatment with dexamethasone is a really strong treatment for the mother, and we know that there are some influence in the brain evolution of the fetus. So I think it is important argument the prenatal treatment with dexamethasone.
Well, the question is, what do you define as high-risk pregnancy? If it's a high-risk pregnancy, I think dexamethasone is contraindicated, so you must not give dexamethasone because then you have an even higher risk pregnancy. So that's clearly something one shouldn't do. For whatever reason it is a high-risk pregnancy, then dexamethasone is not an option. Otherwise, we know that there is a good effect on preventing virilization, and it should be done only in a trial setting. There's no trial yet, but we will have one very soon. So we have one now that will be set up as an international trial, or we started. We can recruit patients in autumn about, so everything is set up now. And then I think within a clinical trial, it can be done because we are doing it since 30 years, except Swedish physicians or endocrinologists, I think. But otherwise, it's done experimentally, but without standardized procedure, documentation, and so on. And when we need to finally know if this treatment should be completely banned or not, and this can only be found out with a clinical trial. So I think we need to do it within a trial, and hopefully we can start very soon.
Yeah. Okay.
Luca, I think you have to,
There is another question about dexamethasone treatment during pregnancy to prevent fetal virilization if we have a high risk in a classic form.
Yeah, that's the only indication where we give it. Only if we have a risk for a classic form in the fetus, then you do a prenatal non-invasive sex determination first. In early pregnancy, if we know it's going to be a male fetus, then we don't start dexamethasone treatment, and you can experimentally still treat then females until you can then do the genetic diagnosis via chorion villus sampling biopsies in about week 11, gestation in week 11, and then stop treatment if the fetus is not affected, and you can continue. But it's experimentally, and it should only be done in a trial setting, or at least in a center where you have experience with it, to monitor closely effects, and also a follow-up should be guaranteed of the mother and the fetus, that we have really outcome data.
Yeah. Okay. I think it was a very nice opportunity to have Nicole speaking about the pregnancy in CAH, and it was very informative, the talk, and we had a rather long discussion with different aspects that were assessed during the discussion. So I think we can be satisfied as chairs, don't you think so, Olaf and Giorgio? And we can say bye-bye to everybody, to the MTG7, MTG1 population of Endo-ERN, people of Endo-ERN, and see you next time online. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.
Webinar, and bye-bye to everyone. Bye.